Welcome everybody to this webinar. This webinar is being organized by a project which is called School of Acute Medicine. So this is a project which has been set up by Academic Forum for Acute Care Physicians in Bangladesh. Group of it's an organization which is trying to promote acute medicine as a specialty in Bangladesh. So that's one of the organizations who has worked to put together this project, and they're working with an online medical school which is called Access Medical School. So Access Medical School is basically a quite well developed and popular online medical school in Bangladesh, which promotes online medical education and organizes various projects and workshops. They do organize quite a number of in-person workshops as well, but with the COVID pandemic, things have become quite a lot online as well. So Access and AFACP has together joined to start a project which is called School of Acute Medicine. The whole idea of this School of Acute Medicine is to kind of be an online platform which is free and accessible to all, mainly with the idea of helping disseminate knowledge on acute medicine among the doctors of Bangladesh. And basically with this webinar today, they're kind of starting their journey. So from today, they will be organizing regular, roughly one per week webinars on acute medicine, trying to get experts from Bangladesh and other countries as well, giving talks on different topics related to acute medicine. And also we'll be sharing educational materials and resources and guidelines on various topics related to acute medicine. So that's the project. We have got distinguished experts from Bangladesh and UK. So I'll just give a quick introduction to the panel of experts who are there. So we have Dr. Cooper, Nicola Cooper, who is one of the leading acute medicine specialists and one of the leading experts in medical education in the UK. She's a consultant physician in acute medicine in the Royal Derby Hospital, and she's also a clinical associate professor in medical education in the University of Nottingham. She is author of multiple books, including also being a chapter author of Davidson 23rd edition. She's written a chapter called Clinical Decision Making, Applying Clinical Reason. And she's also authored multiple other books, so it will be a big list, so I will not go into that. So she's also the training program director, education in East Midlands Deanery of England. So she'll be giving a talk on how acute medicine operates as a specialty why acute medicine was set up as a specialty in UK in the first place, how it has helped develop hospital-related healthcare, which other countries follow this model as well. After that, Dr. Salam Al-Alusi, who is one of the chief registrars of Leicester Royal Infirmary, who is the chief registrar of Leicester Royal Infirmary. Leicester Royal Infirmary is part of the University Hospitals Leicester Trust, which is one of the largest hospitals in the entire UK in terms of daily patient attendances. I was reading that day a statistic that in 2019-2020, it was the third busiest hospital trust in the whole of UK in terms of daily patient attendances. So Salam is currently the chief registrar of Leicester Royal Infirmary. He's one of the acute medicine trainees in East Midlands Deanery Health Education, England, and he'll be giving a talk on how acute medicine operates as a specialty in a particular hospital, using the LRI, Leicester Royal Infirmary, as a model. He will also give a talk on how it interacts with other departments, the emergency department and the subspecialties as well. And he'll also give a talk on ambulatory care. So then we have Dr. Mohsin Zaman, who is a consultant in acute medicine and critical care medicine and general medicine at Northampton General Hospital. And he is the clinical lead for acute medicine there as well. He's also one of the college tutors of the Royal College of Physicians. Dr. Zaman will give a talk on the daily role of a consultant in acute medicine, daily role of a consultant in acute medicine. And after that, we've got Dr. Siddiqa Hassan Rashad, who is one of the ST4 acute medicine trainees ST4 trainees in acute medicine and critical care medicine in the London Deanery of Health Education, England. Dr. Siddiqa Hassan is also one of the fellows of an organization called Take Aim. This is an organization which is run by nationally recruited registrars in acute medicine. And this organization basically tries to promote acute medicine as a specialty in UK. We've got distinguished experts from Bangladesh as well. So we have got Professor Dr. Titu Miah, sir, who is one of the leading general medicine physicians in Bangladesh. He's also principal of the largest medical school in Bangladesh, which is Dhaka Medical College. He's also one of the professors in Department of Medicine in that hospital as well. We have got Dr. Rabbani sir, who is one of the leading critical care physicians in Bangladesh. He is a consultant in critical care medicine and internal medicine in Square Hospital Limited, which is one of the largest private hospitals in the country. And we have Dr. Ahmed Morsel Anam, who's one of the associate consultants in critical care and the COVID unit in Square Hospitals Limited. We also have Dr. Shihan Haq, who's also one of the associate consultants in the critical care department and the COVID unit of Square Hospitals Limited. So with this introduction part, I'll probably waste no further time and give the floor over to Dr. Cooper for your talk, and you'll take it from there.
Thank you very much. So my remit is to explain a little bit about how acute medicine came to be, or officially it's called acute internal medicine in the UK, and what's happening in other countries as well. So I'm briefly going to cover, why acute medicine was born, but also the impact it had. So subsequent studies that have been done which show impact on length of stay, mortality, and so on. And then just a little bit about acute medicine in other countries. So the first thing to say is that acute medicine has a definition, and it's defined as that part of general internal medicine that's concerned with the immediate and early specialist management of adults suffering from a wide range of medical conditions who present to or from within the hospital requiring urgent or emergency care. Might seem a bit convoluted, but it's to distinguish acute medicine from emergency medicine, or what we call A&E. People from other countries often get that confused. It's not intensive care medicine either. It is really a specific branch of general internal medicine in a way. I like to think of it as general internal medicine at the front door. It's really concerned with looking after patients for the first 48, 72 hours. And because, for example, nearly half of all patients who need admission to hospital in the UK only need a 72-hour stay most of the time. The training involves training in general medicine, geriatric medicine, intensive care medicine, and increasingly point of care ultrasound as well. It's only a recognised specialty in the UK. So it would be recognised as general internal medicine in every other country at the moment. If I go to work in a different country, I would describe myself as a general physician with a certificate in general internal medicine, because acute medicine wouldn't be recognised necessarily legally. It is spilling out into countries in Europe, so Holland, for example, and further afield, Singapore and New Zealand in particular, which I'll talk about. Acute medicine, although it literally covers every medical presentation, we tend not to deal with conditions that would go straight to a specialist unit, like a coronary care unit, an intensive care unit, or a stroke unit, because they're specialist units in the UK. So why was acute medicine born? Well, it was born really in the early 2000s. So we're talking 20 years ago now. And I'm just trying to remember where I was in 2000, but in those days, maybe similar to, I know it's similar to where I've worked in New Zealand, and certainly in places like Australia. We used to do what we call safari ward rounds. In other words, we went on a trail around the whole hospital because patients were admitted to any available bed. A&E departments were overcrowded. There were always queues of people waiting to come in, and the patients would go everywhere. And with the rising number of admissions, this sort of became not only unsafe, but also really impractical. The team that was on take or on call would just be overwhelmed with work, while other teams that were sort of waiting to be on call next would have less work to do. So this idea that patients should maybe come to one place, or that admission should be centralised, assessed, stabilised, and either discharged immediately or moved on to the right place for them. That's how the idea came about. Also, the idea that a consultant presence for 12 hours a day, so between the hours of 8 a.m. and 8 p.m, 7 days a week, that was also an idea that came with the specialty of acute medicine, and that is a national standard in the UK. So there was this idea that it could be safer, it could be more efficient, that we could discharge patients more rapidly with rapid outpatient follow-up if needed, because the context, of course, is that in the UK, we have what's called the 4-hour emergency standard. People can only spend 4 hours in the emergency department before either being discharged or admitted to the hospital or transferred, for example, to the ambulatory care centre. And so that pressure meant that more people were being admitted. Acute medicine also really led on short stay wards and same day emergency care. And I'll go through those as well. This is an example model of an acute medical unit. They're also called medical admission units or medical assessment units, but this is the ideal. This is taken from a Royal College of Physicians document. So the typical acute medical unit, this is the place where all the medical admissions come, would have a bed base, a number of beds that's sufficient for your average daily take. It should have teaching and seminar rooms attached to it, and other facilities. One of the key features of a good acute medical unit is specialist inreach. So where I work in Derby, for example, if I go and see a patient admitted with a complicated exacerbation of Crohn's disease, I will allocate that person to gastroenterology, and the gastroenterologists will come and see that patient. And our specialist inreach is twice a day, morning and evening. So all the patients who get admitted with non-ST elevation MIs will get seen by a cardiologist after we have assessed them, started them on the right treatment, organised the necessary investigations, and decided that they should be under a cardiologist. So specialist inreach is really important. So is really good access to radiology and other diagnostics. For patients who we can't send straight home after a few tests, they will move to either a short stay unit or to a specialist bed, which the consultants or the registrars in acute medicine will decide based on what's best for the patient. Most acute medical units need to work really closely with emergency departments, where we typically work very closely with them and often go down there quite a lot. Also, we need to work closely with intensive care, and we need access to a HDU type area as well. Where I work, the last time we measured it, the average length of stay in our acute medical unit was 8 hours. So that, and our admissions unit roughly admits 100 patients in every 24-hour period, but that goes up even more in winter. But the other part of acute medicine that's really key is short stay wards. And that's because in the UK, partly because of this emergency standard, so people can't linger in A&Es, actually about half of all the patients admitted to UK hospitals only need to stay 2 or 3 days. These would be conditions like thunderclap headache needing CT, LP, or perhaps exacerbations of COPD or asthma, problems with diabetes and so on. The problem is that if you were admitted to an ordinary ward, but you actually had a short stay condition, you would end up staying longer in hospital, not because of your clinical need, but because back in those days, ordinary wards had a consultant ward round 2 or 3 times a week. And junior doctors sometimes wouldn't necessarily have the skills to make decisions to send people home. So being admitted to an ordinary ward, and still to this day, artificially increases your length of stay, unless you go to a short stay ward. On a short stay ward, there are consultant ward rounds typically twice a day, but also they have rapid access to multi-professional assessments such as physio, occupational therapy, mental health. They often have pharmacists based on the ward and so on. So the whole thing of a short stay ward, it's set up to give targeted care for short stay patients. I'll just mention one thing about short stay wards. Many years ago, one of my colleagues set up a winter short stay ward for the elderly. This was during the 2009 flu pandemic. And so instead of just outlying patients all over the hospital where they would just end up artificially staying for longer, she set up a dedicated older person, so that's over the age of 80, short stay ward. It was amazingly set up with all the physio and OT and pharmacy and admin support that you could want, 2 consultant ward rounds a day, junior doctors. The problem was all the relatives kept complaining. They had a lot of complaints. My mother is going home too quickly. She's only been in there for a day. And my friend was very perplexed about this because they were actually giving good care, comprehensive geriatric assessment and care. And I said, do you know what? I said, the problem is you need to put a sign on the door. You need to have a big sign that says short stay ward. And you need to have a leaflet that says this is a short stay ward and what we do. And as soon as they did that, guess what happened? All the complaints went away because people actually understood the concept of what happened on a short stay ward. The other thing that acute medicine runs in the UK is same-day emergency care. Same-day emergency care is the new name for ambulatory care, and it's moving in the direction of being able to look after people who are not ambulatory, who might be on a trolley. But currently most hospitals have what's called ambulatory care centres, so that's the walking wounded. And you'll hear a talk about that in more detail later, but it's basically things that we used to admit people for. So, for example, when I was a junior doctor, well, please don't laugh, but when I was a junior doctor, there was no such thing as low molecular weight heparin. And so people with a possible DVT were admitted to be started on an IV heparin infusion, and which the poor old junior doctor, me, had to take the APTT every 6 hours. And they would wait for days for their venogram. Of course, now it's extremely rare. It's an exceptional case, severe case, when a DVT would be admitted to a UK hospital. Same, there's a lot of evidence about ambulatory care for pulmonary embolism. And we tend to deal with conditions like anemia, headaches, chest pain, low risk conditions. And there are usually set criteria, which I'm sure Salam will talk about later. But the key is to have radiology support and diagnostic support. That's absolutely key. So what about the impact? So this is, I'm going to show you a few studies, but this is just talking about medical admission units or acute medical units. It's not talking about the impact of short stay wards or same day emergency care, which undoubtedly have had a massive impact on reducing admissions to hospital in the UK. But here is a study done back in 2007. This was done in Dublin. This is in the island of Ireland, where there was no such thing as acute medicine. But one of the authors was very interested and used to come to Society for Acute Medicine conferences. And they did an experiment where they just took 2 normal wards that were next to each other and they turned them into medical admission units. and they ran them on a medical admission unit model. So that's the consultant presence, the access to diagnostics and so on. And they significantly reduced their hospital length of stay, their overall hospital length of stay. Length of stay became less varied between medical teams. And this quicker turnaround of patients did not lead to increase in readmissions. So they were still doing things properly, if that makes sense. And the measures that they made were done over the following year. So this is a before and after study. In 2008, it was reported they did the same thing in Chelsea and Westminster Hospital, and they again significantly reduced their hospital length of stay. And there was also a slight reduction in mortality. And again, this is not taking short stay wards or same-day emergency care into account. And this study looked at what's the effect of having a consultant. So this the standard of a consultant between 8 a.m. and 8 p.m. 7 days a week. Well, just looking at the effect of a consultant presence reduced, the consultant reduced the total hospital length of stay by over 1 day. And it might sound small, but this really adds up across a whole hospital that is admitting a large number of patients. No difference in readmission rates, so the consultants weren't doing risky behaviours, and no difference in mortality in this particular study. And the reduced length of stay was greatest, the greatest effect was seen in short stay patients. And a systematic review was published in 2016. And so they looked at varied models. I think in total about 12 acute medical units they looked at that had published empirical studies. And the reduced length of stay in all the analyses ranged from 0.3 to 2.6 days. So reduced length of stay. Mortality was a bit difficult to judge, but it ranged from not much change at all to minus 8.8%, which is very significant. Again, no difference in readmission rates. And in this study, there was obviously variation in admission criteria, whether they took patients from A&E and primary care, consultant work patterns and so on. So it was quite varied models. So I think it's fair to say that just the idea of creating a dedicated area to which all admissions, medical admissions come, apart from those that need to go to other specialist areas, where there is a senior presence, dedicated access to investigations, and it's geared up to assess and treat people rapidly in order to reduce artificial delays. That actually makes a difference, and it's a simple system change. We haven't necessarily changed the way we practice medicine. So finally, what about acute medicine in other countries? So Holland has something called DAM, which is quite appropriate for Holland, which is a country full of dams, and that's called Dutch Acute Medicine. And we've had a joint conference with them. It was called SAMDAM, which was in Amsterdam, funny enough. And but also the acute medicine specialty certificate exam is going to be mandatory in Singapore for people specialising in general internal medicine. In New Zealand, all consultants consider themselves specialists in acute medicine because that's what general medicine is in places like Australia and New Zealand. So many of them don't really understand what the difference is. And of course, hospitals there can be quite small. But when I worked in New Zealand for a few years, the hospital where I worked has now, it did have an admissions unit. What was interesting there was that patients were initially seen in the A&E department. And if they were obviously long stay, they would just go straight to an ordinary ward. But those who were suitable to be turned around quickly in an admissions unit were sent there. So again, that's a sort of hybrid model, which makes sense. And they've also developed an ambulatory care centre as well, having visited Derby. You might have heard of the hospitalist movement in the USA. it's a very different model, but it's this idea that instead of the GP basically looking after you in hospital and referring you to specialists, there's a dedicated internal medicine physician who does all that for the GP. And that is growing in the US. But a lot of the principles we've used in acute medicine, which are really all about systems, reconfiguring systems, can be adapted to small or greater degrees to many other countries. And recently I wrote a paper about a case of diagnostic error in Zambia. And one of the things we talked about was the simple introduction of early warning scores, which are very simple, could have prevented that patient's deterioration. So there's things you can take to suit your own local needs, and that of course will differ between rural and large city hospitals as well. So that's the story of why acute medicine was born in the UK.
Yeah. Thank you, Dr. Cooper. That was really quite informative and quite useful. So we will probably keep the questioning session at the last. So what I'll do now is I'll ask Dr. Al-Alousi, who's, as I said, who's one of the chief registrar, who's the chief registrar at Leicester Royal Infirmary and one of the acute medicine trainees in East Midlands Deanery, Health Education England, to kindly give a talk. And he's going to talk about ambulatory care and how acute medicine as a department operates in a particular hospital using the Leicester Royal Infirmary as a model and its relation with the subspecialties and the emergency department.
Thank you, Latif, and thank you for the kind introduction and for inviting me to give this talk. Hopefully we can cover a bit about ambulatory care, which I think has changed the way we function as acute medics in the hospital, and also has made a huge difference to, in particular, emergency medicine, how they operate, particularly over the COVID pandemic, when our ambulatory care, at least in our hospital, took a lot of the burden from the emergency department. So like Latif said, my name is Dr. Al-Alousi. I'm one of the acute medicine registrars and also the chief registrar at the Leicester Royal Infirmary this year. And I'm just going to go through ambulatory care, how it started, why it was, why it started, and in fact, what is ambulatory care, who is suitable for ambulatory care, and the scoring systems that have been developed to try and get the appropriate patients sent to ambulatory care, and also the challenges and the future of ambulatory care as it's developing into something much larger than what it started off with. And then going to briefly talk about how acute medicine operates in the Leicester Royal Infirmary. Obviously, it operates differently in different trusts and hospitals, but broadly speaking, things are relatively the same across the UK. So what is ambulatory care? Well, the Royal College of Physicians have defined it, and this was published in 2012 based on Ambulatory Emergency Care for Adults Directory, which was published in 2007. Ambulatory care is clinical care which may include diagnosis, treatment, and rehabilitation not provided within the traditional hospital bed space or within the traditional outpatient services, and then can be provided across the primary secondary care interface. And you may have heard Dr. Cooper mention that the name has changed now to same-day emergency care, which probably is more reflective of what we currently do with our patients in the ambulatory care clinic. And the idea is to streamline the patient journey. In the UK, access to specialists, including medical specialists, is limited in terms of you need to be referred or you go privately. And referral goes via primary care, which is made of a group of doctors who are general physicians, who we call GPs, who then determine if you need to be referred. And then when you are referred, you often are waiting a number of weeks with a growing waiting list to see a specialist. However, there are some things that can't wait. And so traditionally, these patients would be asked to go to the emergency department or be referred directly to medicine in the hospital. And at that, when I first started in medicine, there were enough beds to give these patients a chance to be seen within 24 hours at least by a medical specialist, as in they would come in, occupy a bed, and then be seen. However, over the years, with growing bed pressures and the number of unwell patients, particularly of the elderly population, often these patients were waiting for many hours, including possibly even days. And so going to the emergency department was the next sort of safest or the next best thing, and obviously not ideal, given that it would then clog up the emergency department with non-emergency, well, technically non-emergency things that could be seen by a medical specialist in a different setting. So really, the pathway traditionally was that either primary care would, so the GP would either see the patient and think, yes, I think this patient needs to be seen by a medical specialist as soon as possible, would then phone in to a line called the bed bureau line in our hospital, who would then assign that patient a bed and contact the patient and get the patient in. Or the patient would come to ED directly. So if they thought there was an emergency, come to ED directly, and then if the ED specialist would then see them and determine that they need to be admitted to medicine to see a medical consultant or a decision maker within sort of a day. And then that decision maker would either discharge the patient, which, as you heard from Dr. Cooper, many of the patients would just be in hospital for 48 hours, or determine that actually they need longer and go to the ward. Now, with the problems with this is that the patients that were waiting, obviously their care was being delayed, and obviously there were long waiting times for outpatient services. For example, if you wanted to see a neurologist, then I understand their waiting time at our hospitals is a few months. And so there were delays in getting patients seen. But also those patients that ED determine need to be seen by medicine, because of the bed shortages, they were sitting in ED waiting for beds, when in fact they probably just needed to see a specialist, have a plan in place, and then could probably go home. So they were waiting in hospital, not because they were very poorly, but because they needed to see the right person, and they were in the wrong area. There were, in our hospitals, there's a limited number of beds. So at the Leicester Royal Infirmary, there are around 1,000 beds. And so to create space for patients coming in, typically patients who had been in hospital for days, who were stable, medically optimized, they would be outlined to non-medical wards whilst they await whatever is delaying them from being discharged. So typically, things that to do with social care in particular, awaiting carers, awaiting nursing homes, awaiting residential homes, would be the thing that would be the bottleneck in discharging these patients. But that would mean that these patients would then be on a different ward, different environment, new staff, and possibly being looked after by non-medical sort of doctors. So doctors who are on an orthopedic ward, for example. So not ideal. As I said, there was a delay in seeing the decision maker. There was a lot of repetition of work. So those patients that the GP thought needed to see medicine, who then ended up in the emergency department, would then be seen by the emergency department team and do much of the same work that the GP has already done. And in the end, not come out with an answer because they are not the medical specialists. And so often we find patients asking I've answered these, I've answered these questions. Why are you asking again and again? And so a number of different doctors would see the patient, but not really achieving much in terms of, organizing a management plan for that patient. The reduced throughput and revenue. So all these things cost money. And so costs were high, as well as waiting times. With the lack of sort of what we call patient flow through the hospital, there is a lot of stress put on the staff to discharge patients. And so often bed managers would say this patient needs to go, and that would lead to a lot of stress for those working on the wards in terms of getting their discharge letter sorted, doing things as promptly as possible to get that patient to leave. And that could distract from the patient care. And so it can affect patient care, and things can go missing, especially if you're looking after a ward of patients who half of them are in the same sort of situation. Hospital stay, as we all know, increased hospital stay can lead to harm. And hospital-acquired infections is a particular risk for these patients who are needing to stay in hospital just to see a decision maker, rather than because they are actually poorly. And so they do tend to pick up infections. And also, last but not least, is the experience of the patient and the dissatisfaction. So the patient has gone through, huge waiting times, has seen a number of doctors, and does not yet have the answer to their query or their problem, and also does not have the reassurance until they then see the decision maker, who in a lot of cases will then say, well, this test can be done as outpatient. No, I don't think you have this problem. We can discharge you. And so the patient is left feeling, why have they been here for over 12 hours or even longer? So with the same day emergency care, if we introduce now ambulatory care service here, you'll see that now we have somewhere the primary care can directly refer patients that they think need medical opinion, sort of on the same day, and then they can have their all the necessary tests that they need, including CT scans, ultrasound scans, blood tests, and also seeing other medical specialists like a neurologist or a dermatologist on the same day. And actually this is also open for the emergency department, who will see a patient, for example, if they have a thunderclap headache and think, okay, this might be subarachnoid hemorrhage, but does not necessarily need to be admitted. So it just needs to be seen in ambulatory care, have a CT head, be seen by a decision maker, and then maybe even a lumbar puncture, and everything can be done within 24 hours. And also many patients can be managed as an outpatient, and do not necessarily need things to be done the same day, but they need a decision maker, someone who is experienced in that condition, to then make that decision and refer accordingly. But then also patients who are then seen in ambulatory care, around 10 to 15% of them may need admission anyway, after they have a medical plan put in place. So they may then end up on the ward or short stay ward, or they may go home and discharged. And that's sort of the a very broad, basic view of what ambulatory care is at the Leicester Royal Infirmary anyway. And as I said, over the COVID pandemic, the ambulatory care clinic expanded significantly to try and take the strain off of the emergency department services. And so we were actually seeing anyone who's able to walk, who comes to the emergency department, who has a remotely medical problem or medically sounding symptom, were then seen in the ambulatory care clinic that was running over 24 hours. So that was extremely beneficial to the hospital to try and get through patients to flow through the hospital. So as I said, the ambulatory care clinic, it allows for bypassing of ED, reducing the strain on ED. And I think that makes a significant difference, especially for patients who are already seen by a doctor in the community, and that doctor thinks that this patient needs medical input. And actually over 30% of referrals are being managed in ambulatory care, so do not need to occupy a inpatient bed. As I said, they also improve the patient journey, see the specialist quicker, reduce length of stay, or what we call emergency bed days. So all the beds in hospital are emergency beds, or rather at least the admission unit beds. Reduce the patient harm by reducing length of stay, but also the risks of hospital-acquired infections, DVTs, etc. Improve the patient flow and therefore improve the patient experience and satisfaction, and reducing the cost. But also there is more support of primary care. Primary care are very generalist in terms of their expertise, and they often do need advice and input for some patients that come and see them. So having this in place gives them somewhere to refer. Now, things that we commonly see in our clinic, things like low risk chest pain, cellulitis that where the patient's not septic, suspected DVTs and PEs, suspected infections that require IV antibiotics and may just require a clinical decision maker to see them, determine whether they do need admission or whether they can be treated in the community. So things like cellulitis can be treated with IV antibiotics in the community. We do have a cellulitis pathway that allows for that. Headaches where they're very severe and may suggest something serious is going on, we also see as well. And in some cases, we also see poorly controlled hypertension or even malignant hypertension, where the patient's fairly well, but the GP is obviously worried with a very high blood pressure. And we also do see different neurological symptoms, not acute strokes, and also collapses. And there are various scoring ways to determine whether the symptom they have or the problem they have is low risk. For example, in DVT, we have Wells score. In upper GI bleed, we have the Glasgow-Blatchford score. And so we do use these scores to determine what happens to these patients. But also, which I'll come to later, is other scoring systems which we use to identify patients as well. So I did mention that ambulatory care was expanding, and now we are seeing patients who are then told to come back after a week or after 2 weeks to the same area to then have a follow-up appointment. So now we're following up these patients, and we're doing our own sort of repeat blood tests and repeat monitoring. There are a number of services available in the community. As I said, the cellulitis pathway, allowing for district nurses to come in to the patient's home and administer IV antibiotics as long as they are determined to be clinically well. And then we're also having patients who attend for certain procedures. For example, patients who have known malignancy, who require regular drainage, or perhaps they are symptomatic and they require acidic drains, for example. We're having these patients attend and having their acidic drain and then going home. We also have same-day clinics for IV infusions, for example, IV iron, blood transfusions, that sort of thing. They're also happening in our clinics. So the Royal College of Physicians has principles that they have suggested, 10 principles they've suggested for ambulatory emergency care, and I'll just briefly go through them. So number one is that the redirection of patients to ambulatory care should be led by a senior clinician who has the expertise and the know-how, and also aware of the different available services in the community and in the hospital, to determine if that patient should come to the ambulatory clinic or whether they should go elsewhere. And there should be clear exclusion criteria based on the early warning score, which is a score that's developed nationally to do with blood pressure, heart rate, oxygen saturations, and other observations to determine if that patient is basically, needs to be more closely monitored than others. The location has to be close to A&E. It should have the staffing resources to offer rapid assessment, diagnosis, and treatment on the same day. So, for example, in our clinic, we have same-day CTs are possible, same-day ultrasounds, same-day Doppler ultrasounds, for example. So we have services in place to allow for this to occur. The targets should match clinical quality indicators for ED. So the ambulatory clinic is not somewhere that the ED department can send patients who are breaching or waiting, outside 4 hours. Just because we're outside of ED does not mean we should not adhere to certain standards. So being seen and dealt with and managed within 4 hours is still a target that we should try and attain. Addressing expectations of the patient. So the patients obviously have their own expectations, and some of them will be expecting to come into hospital and stay, occupy a bed and stay for a few days. So addressing their expectations is important, because if they're seeing the ambulatory care, then most likely they probably won't be staying in hospital. Trying to avoid full admission by collaboration with primary and secondary care. So often we have patients that we can manage in the community, but there needs to be some primary care services in place to allow that. And obviously training of staff to allow for the ambulatory care clinic to run, keeping record of discharge summaries, and also, sending the discharge summary to the primary care or their GP so that they're aware of what's happened. And lastly, work with commissioners to record the activities that ambulatory care has, so that they can keep track of what's working, what's not, and the costs involved. So like I said before, who is suitable for ambulatory care? Well, it's based on 4 questions. Is the patient clinically stable? And usually that also includes some sort of early warning score, some sort of record of their observation. Now, the reason I mentioned that is important given the context of what's happened around COVID with primary care in the UK. Number 2 is the patient functionally capable of being managed in ambulatory care? So, for example, if they have dementia, are wandering, not obeying commands, it may be difficult to manage them in ambulatory care where the staffing and the nursing resources are limited. Number 3 is, would this patient have been admitted to hospital before ambulatory care existed? So if the answer to that is no, then they should not be referred. So what this is trying to say is that, does this patient need emergency care today? Because if the answer is no, and they've had sort of a symptom for a number of months or weeks, then perhaps there are other services available that they can be referred to, and they can then seen in due course rather than same day. And then lastly, could the patient's clinical needs be met better by another service? So for example, specialist nursing clinics, other community services, etc. Now, one of the ways that they've found to sort of try and pick the right patients to come to ambulatory care is by developing certain scores. And there have been 2 that I'm aware of, at least: the ambulatory care score and also the Glasgow admission prediction score. And the idea is to get the patients who are most likely to go home on the same day or most likely to be discharged to be seen in ambulatory care, and that way free up an inpatient bed. However, over COVID, there were some issues with this. both of these scores take into account the early warning score, which includes blood pressure, heart rate, etc. And so over the COVID pandemic, we had primary care, which was operating, mostly, or some of them at least, under sort of telephone consultations with patients, where they were not able to check their blood pressure over the phone. And so fulfilling these scores was a bit of a challenge. And I think at my hospital, at least, we've started using the GAP score now. And we're trying to see if we can develop another score to try and, whilst this COVID pandemic is going on, that will sort of work the same way. Challenges and the future of ambulatory care. Well, I think ambulatory care requires a change in mindset of physicians, I mean. We no longer can sort of keep a patient in hospital just to observe, unless it's clinically required. But if a patient can go home and it's safe to do so, then they should initially, they should go home. And so that traditional inpatient observation doesn't exist with ambulatory care. So there has to be a change in mindset of the physicians who are running the ambulatory care. And I think that's where acute medicine physicians come into play, because not only are we sort of, we have expertise in wide number of areas in medicine, but also we understand the importance of bed management, and also understand what services are available in the community and what services are available to allow for a patient to go home safely. The other thing is primary care. I did say that primary care supports, ambulatory care supports primary care, but there can be a tendency for the primary care physicians or doctors to overuse the service if they know it exists. And so that's a problem going forward. Patients who are seen in ambulatory care need follow-up of their investigation. So there has to be a robust system in place for those who are seeing them to follow up investigations. Primary care won't do that for us. So it's an ongoing follow-up that's required. And as I said about the COVID, the issues around the COVID pandemic, there were difficulties in selecting the right appropriate patients. But also some of the things that are coming into play as new tests are developed. For example, the high sensitive troponin, it's allowing for pathways to be put in that can be managed in ambulatory care. For example, the low risk chest pain pathway. Now, just briefly going to talk about how acute medicine fits in at the Leicester Royal Infirmary, at least, or in Leicester, with the rest of the hospital. So when I first started acute medicine, or a number of years ago, there were essentially 3 admission wards. Now this expanded to have, we have an AMU East, which is a 10-bedded admission unit. We have ACB, which is our high dependency unit in medicine, which has 10 beds. We also have AMU West, which is a 22-bedded area admission unit as well. AMU North, which is a 28-bedded area, and AMU South now, which used to be our short stay unit and is now another admission unit, again 28 beds. So we're looking at 130 admission beds in the hospital for medicine, and so that's a lot of beds. And so a large number of the patients that come into hospital come through AMU. We also have the GPAU, which is the name for our ambulatory clinic, and AFU, EFU, which is again admission units for frail patients and is run mostly by geriatricians who are interested in acute care. And then over at the Glenfield, we have another admissions unit, which is the clinical decisions unit, which is mostly where our cardiorespiratory patients go And again, this is an area which I would say compares mostly to emergency department rather than an admissions unit, as it has both admissions unit and a sort of triage area where it can take patients. And I've been there where we've had 60 patients in the unit, so it's a quite a large unit there. Now, how do patients get referred to medicine? So we get patients referred via GP, as I said before, and they either go to ambulatory care or directly to medicine, or if they need admission, then they go through to ED, and if there's no beds, I mean. And there is a registrar and also a consultant on call that can take that referral. If the GP needs to speak to someone, there is someone to speak to ask for their advice about a patient. In the emergency department, we have acute physicians going in what we call an in-reach service now, who can then see the patients basically at the front door. So after they're seen by the emergency department, we can see them very quickly there, rather than wait for them to come into the admissions unit and see them there. And also the acute care bay, where patients who are very sick, who have severe sepsis, who have type 2 respiratory failure requiring non-invasive ventilation, who have diabetic ketoacidosis or very significant overdoses, who may not qualify to go to intensive care, we take them to the acute care bay, and the registrar is asked to see them in the emergency room if there's no beds available. We do get referrals from the surgical specialties. So, for example, the orthopedic ward will often call the on-call medical registrar to ask for advice about a patient who has had recent hip surgery, for example, and is now developing what sounds like a pneumonia and dehydration and other sort of medical problems. And so there is that there. And we do get referrals from other medical areas in the hospital for the acute care bay, as it's one of the sort of specialized area in medicine where there's more nursing available to look after the patients. But also we tend to do things there that we can't do in other areas, for example, non-invasive ventilation. So we do get referrals from oncology and hematology for their patients as well. I've just drawn this sort of diagram just to illustrate really how acute medicine sort of fits in as the with the sort of specialties of emergency department and critical care. So, and this was particularly relevant over the COVID pandemic, where patients with COVID pneumonitis, who were very hypoxic, both critical care and acute medicine were involved in determining where best for them for the patient to be looked after. And we were working closely together to sort of put in plan pathways and things to ensure that the patient goes to the right area. And I think from my point of view, acute medicine is sort of, as Dr. Cooper said, it's general medicine at the front door, but also with the understanding of not only the bed management in the hospital, but the understanding of many areas of medicine and the available sort of community services. So with that understanding, then determining how best to manage the patient, either in hospital or out in the community. And I think that's the last slide. Yep. So thank you. I'll stay for any questions after Dr. Zaman's and I think Tig's talk.
Yeah, thank you, Salam. So that was a lovely and brilliant talk. Like, it was quite extensive, and you covered most of the things that acute medicine as a department should be doing. And the talk on ambulatory care was quite lovely. So, without waste, I'll probably just now ask Dr. Zaman to kindly give a talk on the role of a consultant in acute medicine on a daily basis. And for people who missed the introduction part, Dr. Zaman is one of the consultants in acute medicine and general medicine and critical care medicine at Northampton General Hospital. And he's also the clinical lead for acute medicine in that same hospital. He's also one of the Royal College Physician College tutors. And he's also one of the mentors of point of care ultrasound and echocardiogram. So Dr. Zaman, I'll just hand over the floor to you.
Thank you, Latif, for that very kind introduction. I'm going to start. I've been asked to give a talk regarding what an acute medic does on a normal working day. And I'm assuming that meant what he does for his clinical life. So I'm going to start with why we chose, or at least why I chose acute medicine, because frankly speaking, as a physician, it was the best chance of me getting work-life balance. And this is just a breakdown of what I spend doing during a year, where you can see that almost 30% of my working days are as a clinician, delivering care at the front door. But the rest of the work I do is a lot, which is almost 2/3 of what I do, is actually outside of the clinical workspace. So moving on, the day in the life of an acute medic is very much depicted in this little picture where you're imagining yourself as the general who has to organize his forces and go ahead and make sure that they are working efficiently for you to have some degree of sanity left at the end of the day. And so the work itself is divided into clinical work. There is also some professional development, which your job would normally involve, and of course, research and development. And most people will have an aspect of all three of these in any given day, or one of these, depending on where the job plans are like. So the typical day for a physician could be divided into those three activities. The way I've organized on my job plan is I either do clinical or non-clinical days, which means that I don't have that variety of doing multiple things at the same time in theory. So the clinical day, whenever I'm on one, is divided into before you come to the ward, what happens on the ward, and what happens at the end of shifts. So first things first, this is teamwork. Nobody works in isolation. So you need to understand and know your team well, because they are what's going to deliver most of what a consultant decides. So before you end up on the wards, you need to know who are the doctors, what grades they are, what experiences they might have, what are their motivators, who are the nurses, what's involved with what are their motivators, what's going on with them, who are the ward clerks, what's a bit more specific to the DGH, where most of my work actually is the fact that you need to know the specialty consultants and at least the ones who are on call, and usually be on very good terms with them. So you not only need to understand the motivations of your workforce any given day, you also need to know their strengths and weaknesses. And you need to keep that in mind when you're attributing jobs or just trying to decide what they ought to do. Now, motivation can be found in a lot of ways. I think the picture depicts a rather cruel way of motivating people, but we are where we are. There are other things to know, like what the bed state of the hospital is. The term usually implies how many beds there are available, what's the occupancy rate, how many people are stranded, how many people are likely to be discharged. And it just gives you a rough idea of how much pressure management is going to put you any given day as to how much work they need you to, actually not how much work they need you to do, but how much stress they are from the lack of beds, let us say. And of course, you need to understand how many are awaiting coming to accident and emergency. So the beginning of the day usually is greeting and thanking the night team, doing a formal handover, identifying concerns and commending people's good work. And after that, you just make sure that the day team has a well-defined roles and identify the urgent tasks for those individuals from whatever has come out of the handover. Simple example would be asking a reg to go see a patient urgently. Another might be me saying that, why don't you prepare while I go see a sick patient in recess, because we need to make an early decision of where we are going to go. So it depends on the situation, but that's usually the gist of it. that you organize your tasks based on the information you have. And then you end up going to the first key of doing your job as a consultant is be very polite. I've come to realize that you somehow carry quite a bit of authority, even though you don't feel like you do, but you do. And that can be intimidating for certain staff members. And the best way of getting out of that is to be very, very polite. Meet people, greet them, show them that you actually not only you value their work, but you value the fact that they have come, spent their time with you, and they're working. Talk to the nurse in charge. And the focus here is this, that when I talk to the nurse in charge, my focus very much is, who are you worried about? Because we've had a nighttime review from doctors, but they were small in numbers and their focus was whatever somebody highlighted to them. Now, there might have been people who would be highlighted by more senior staff, where the early warning scores might not be high enough, or there might be other things going on, or there's a variation. Either way, it's best to ask the nurse who's in charge on the ward at the very beginning of your shift whether they have concerns. And of course, whether there can patients who could easily be discharged. Now, a lot of the wards at this time would be doing a board round where they go through a quick summary of every patient along with what needs to be done for that day. Acute medicine, at least in the place I work, is slightly different because our patients change so frequently that an early morning board round with limited knowledge of what's there and what's happening usually just causes delays rather than functions as a supportive tool. So we tend to do our first board rounds later in the afternoon when we know what's going on, at least clearly. Okay, so it's a bit less organized than this little picture, but that's the ward. And the team, what you do is you need to realize that, at least in my case, we set expectations early on as to what is anticipated from the doctors who would be working with me, along with other staff members, the pharmacists, everybody else, the specialist nurses. And fact that if a job is generated or a task is generated, what I anticipate its finish time. Okay. And along with that expectation, I also try to make sure that we identify the motivators for the individual members of the team and try to address those. And for me, most of the time, that's starting my day by saying, what are your learning objectives for the day? Or at times asking them, what do you want me to cover from your portfolio today? That very encouragement or that very offer that there would be something beyond just clinical provision of care is being on the offer tends to help. But most importantly, I will ask, what is the plan for lunch? You do need to make sure people are fed and watered and the breaks are appropriately designed. Doctors are very poor at that, at least in the UK, so I anticipate the same is true for everywhere else, but I might be wrong. But I do find that they tend to delay things when they ought not to in terms of looking after themselves. And so I take it upon usually myself to make sure that that is addressed early in the day. The ward round itself, when it starts, the junior doctor presentations are classical case studies of confirmation bias. They tend to go ahead and look for data which reaffirms what they already believe. The problem there is that, at least in my own experience, 1/3 of the time, the diagnosis will be wrong. And so, even though acute medicine has not shown any harm and has shown reduction in stay, one has to be very wary of the fact that you do gather all the data that needs to be collected before you make decisions. You always make sure that your tasks or your jobs generated are very well defined in terms of time, priority, and specialty involved. Identify the appropriate task for each team member. And that might mean that who's going to communicate with what specialty, what's going to be written down where, who's going to arrange. So a nurse might be having a talk with the discharge nurses or the physiotherapists, while you're saying that I'll take on the task of talking to the cardiologist or the respiratory physician or the radiologist. So basically, distribution of the jobs, not just giving them to a junior doctor, but identifying who is the team member most likely to efficiently fill that job. Okay. And patient contact times are limited. And so we do need to be wary of the fact that whatever time we spend with the patient is very much focused on confirming what's wrong with them, making sure what treatment needs to be offered and what the patient's needs and expectations are. Okay. So I rarely do a round where I don't scan people or where I don't examine people. Like I don't remember a round where that has happened. But having said that, one does need to make sure that whatever we do is extremely focused. And the team which goes around doing this is quite essential. So usually it's a combination of doctors, a nurse at least, if not more, pharmacists and nutritionists on and off, depending on who's with me. Now, here's the other thing to keep in mind. When you attend your departmental audits and M&M meetings, they're not just there to do an audit and ensure that you've done your portfolio, but it actually is what stays in the back of your mind, that this is what has gone wrong in the system in the past. What have we done to address it? How likely is that to happen again? And similarly, your audits tell you as to how compliant you are with your national or your local standards. And so when you see patients, you focus on the fact that, okay, we were poorly compliant, let's say, with assessment for need for anticoagulation. So we should focus on it when we are reviewing these patients. And that's another thing that just improves the care that you are delivering. So then comes the board round, which is basically a summary discussion of on the board. Usually should not be more than 30 minutes. And here the idea very much is this, that we make sure that we identify what the patient's needs are to move on in their journey, either to a base ward or home or anywhere else. There might be at times investigations that you need to know what the results are of before you can go ahead and say go to a base ward. There might be investigations which help you decide, okay, actually this patient could go home, or this patient might be more appropriate for early discharge or enhanced discharge with follow-up in ambulatory care. So given all those things are in the back of your mind when you're going to these rounds, it's the things that you need to go through. And usually the rule of thumb I use is I say you should not be spending more than 30 seconds with a patient. And if you are, then something has gone wrong with the round. You do establish team priorities, you action who's going to do what. So here's a little summary. It is an exercise in communication, the board round, and it set tasks as to who's going to do what, when, and how. It sets escalation plans that if you have not achieved any of those tasks, who do you go to? What do you do next? You agree on a follow-up time. In our case, it's usually 3 hours after the first round, where we anticipate that we have enough junior staff to meet the needs of all the patients for whom the jobs have been generated. And so we go ahead and address it at 3 o'clock. And we make sure that these board rounds, there's a tracker present, the nurse in charge is always present, the relevant doctors are present, and the bay nurse is present and able to attend. Along with these, there are other allied specialties who are cordially invited, and we make sure that they feel welcome to attend these, especially if they have input about a particular patient. And so we start focusing on what's called red days and green days. Idea very much being that what is keeping a patient's journey from moving ahead. And as long as the journey is moving forwards, it's kind of okay. But if you get a red day, you start thinking, what's wrong with the system? Why has this happened? What do I need to do that it does not happen again? After that, it comes lunch, jobs, education, meetings, whatever. And this is going to go on happening till you come to the second round. So my usual approach is combine lunch with educational session or combine lunch with a meeting. Either way, lunch has to be a priority. And then you see how things go. Usually it allows for engagement, it allows for people to kind of wind down a bit, because the morning usually is a task which can be stressful. I know that the mornings can be very, very demanding cognitively. And so it's always best that people are rested and watered and fed before they have to go ahead and engage with further activity which requires concentration. So once the second round is done, usually you can go ahead and do whatever other admin work you need to do or focus on communication with relatives, or you can go ahead and do, let us say, any kind of procedurals where people have managed not to be able to do them, or go look at the sickies again physically and reassess and make sure that things are happening as they ought to. And that's about the end of a typical clinical day, as far as I'm concerned. Now, the day itself usually finishes for the acute medics in my hospital at around 5 o'clock. We don't stay any longer. We have an on-call consultant from a specialty who will come and stay till 9 in the evening. And then we would not do any weekends again, because we will have the specialists do those. So that way, life is not too bad. And again, I will have questions once. I'm very welcome to any questions once everybody else has spoken. Thank you.
Yeah. Thank you, Dr. Zaman, for a wonderful talk again. That was quite interesting, and I'm sure that more and more people would want to be an acute medicine consultant after hearing your talk. So I'd now like to hand over the floor to Dr. Sitiga Hassan Rashad, who is one of the acute medicine registrars and also one of the trainees in critical care as well. So she's a dual trainee in acute medicine and critical care. She's currently training in the London Deanery of Health Education, England. She's also one of the fellows of an organization called Take Aim, which is an organization run by nationally recruited acute medicine registrars who, and the purpose of that organization being kind of to promote acute medicine as a specialty. She is currently one of the 7 fellows of that organization and one of my colleagues, one of my fellow colleagues in that organization. So without further waiting for the time, I'll hand over the floor to you. Tig, you're muted.
Sorry, thank you everyone for the talk so far, and everyone that's here today for these talks. And Dr. Zaman's acute medical take sounds very good, and I'd love to work with him one day, and especially because he focuses on lunch. My talk today is just about acute medicine, talk about the training and the role of an acute medic in the UK. Obviously, that will be different for people from different countries, but this is just how our current training works. Funnily enough, it is due to change within the next couple of years, but I do go through that. Well, we already know what acute medicine is, and I'm sure you wouldn't be here for a talk for it today without well, yeah, unless you knew what it was. So just to focus on the fact that we are looking after patients in their first 72 hours of their hospital admission, and that we are largely based on the AMU and ambulatory care, which we've heard quite a lot about today. So what is the training pathway in the UK? So in the UK, you do your foundation years. So you come through medical school, you do your foundation year 1 and your foundation year 2. Where you rotate amongst a number of specialties depending on what deanery you're in and what your selections are. Following that, in order to do acute medicine, there are 2 routes in the UK. You either do kind of integrated medical training, or IMT, which is now a 3-year kind of training program. Again, you rotate through a number of medical specialties over the course of the 3 years, with your 3rd year being kind of like a junior registrar year. It's only just been kind of rolled out, and we haven't really seen the junior registrar year kind of manifest yet, but that is the plan for next year. And then you have the route 2, which is the ACCS, which is a more of a critical care. It's called acute common care STEM specialty. So within ACCS, you can go on to a number of other specialties. You can go on to anaesthetics, A&E, intensive care, and acute medicine, but that's not offered in all deaneries across the UK. It is a 3-year course. It's still a 3-year course, although there are rumours that they're going to expand it to a 4-year course. And unlike IMT, you would have training in anaesthetics within that. So you would potentially get airway trained. You would do an A&E placement, Both actually IMT and ACCS now include critical care placements. So that's how they mostly differ, but both of them in the end you can apply to acute medicine afterwards. During the IMT and ACCS routes, you would be expected to obtain MRCP, which is a series of exams, which I'm sure many of you have heard of, 2 written exams and the PACES exam, which you have to complete essentially before you become a registrar. Following your completion of those 3 years, you then go on to acute medicine. So acute medicine technically takes 4 years to CCT. Now, it may take you longer or shorter, depending on what you incorporate into those years. So generally, you're an acute medic from ST4 to ST7. And during that time, you're expected to complete a specialty exam, which will be in acute medicine, before you CCT, which is essentially becoming a consultant. So in terms of applying, and this applies to kind of the UK, obviously, it's listed as a Group 1 specialty. So there's lots of Group 1 specialties now, but that essentially means that there are, as part of the IMT training, the ST3 year will now be within a kind of a generalised ST3 year, as opposed to entering ST3 as an acute medic, which is what I and Latif would have done. Unfortunately, there was no recruitment for acute medicine this year in the UK. Well, I say the UK, there was some in Wales and Scotland. So I've mainly been in England. And that is because of this change for the IMT curriculum. It's you usually apply via an Oriel system. So you upload evidence of things that you've achieved over your medical career. For example, presentations, posters, prizes, other degrees. And then you get points depending on how you meet those criteria, and then that will lead you to be shortlisted, and then you'll be invited for an interview. The interview is largely now based around kind of clinical skills, so you'll be asked questions about how you would manage certain clinical scenarios, and also your eligibility for the specialty, so showing that you have demonstrated commitment, and also kind of advocating yourself as kind of a leader, team player, etc., with the skill, with the achievements you've brought with yourself in your portfolio. So how has acute medicine changed, and what is the current training, and how will it change in the future? So essentially at the moment, as we've already heard actually, in a lot of countries, they have something called internal medicine. In the UK, we kind of still refer to it as general medicine. So you're expected to kind of get competencies in acute medicine and general medicine. General medicine is kind of a specialty which can coincide a number of other specialties as well. So you can be a respiratory medicine physician who's also trained in general medicine. And it's essentially just so that when you're a consultant, you can manage the acute take. You have those skills to manage a number of different specialties, even though that might not be your home specialty. As I've said already, there's a new curriculum due to be rolled out in kind of 2022. It hasn't currently been completely agreed with by the GMC, but it is listed on the JRCTV website if anyone wants to have a look at it and how things will change. They've essentially changed the word from general medicine to internal medicine. I guess that this coincides a lot more with what people know of general medicine across different countries. Our current curriculum is based around obtaining a number of work-based assessments and supervised learning events over the course of the 4 years that you do acute medicine. And these can be in the way of doing kind of case-based discussions. You can do supervised learning events. You can do something like called an ACAT, which is essentially where a consultant watches you see like 5 patients and you discuss all of them. You also do directly observed procedures or DOPS. Multi-source feedback from a number of different kind of other people that you're working with. And in the new curriculum, you'll be expected to obtain other things like patient feedback as well. So unlike the curriculum at the moment, the new curriculum will focus on something called capabilities in practice. There's a number of generic capabilities which are based around the GMC's good medical practice, which are things like professionalism and leadership, team working, etc. And then there will be 6 specific acute medicine clinical capabilities that you're expected to obtain. And the way to show that you have obtained those capabilities is by doing those things I talked about on the previous slide, which is these case-based discussions, these work-based assessments. And then every year you have an annual review of competency of progression, or an ARCP, and that's where your education supervisor decides whether you've done enough throughout the year to show that you should progress. And then if they say that, say like you should progress, then it goes to kind of a panel of doctors that you don't know, and they will make the actual decision as to whether you should progress or not. So this is just looking at some of the GMC or the kind of generic capabilities that you're expected to obtain. And as I said, they're just based, they're kind of, you know, not necessarily specific things that you can obtain, but they're things that you should obtain over the 4 years. And then this is looking at the AIM clinical capabilities. So again, some of them are very wishy-washy, but essentially you should be able to manage an acute medical service. You should be able to deliver alternate patient pathways, including ambulatory care. You should be able to prioritise patients in a correct way. So I assume with this, you're looking at managing the acute take, you're managing the AMU unit. You should be able to integrate with other specialties, and they've specifically listed ICM, cardiology, respiratory, and geriatric medicine. You should be able to manage complex discharge planning, and then you should also obtain a specialist skill. And as I said, in order to prove that you've done this throughout the course of the training, you do your work-based assessments, you get them signed off by your consultants, and then you go to the panel, the ARCP, every year. And then, so this is just what they've listed of how they'll kind of decide whether you progress or not. But essentially at ST4, you're really not expected to be able to do much of this at all. If you need essentially direct supervision in order to progress. In ST5, it's indirect. In ST6, it's unsupervised, so in ST7 it's unsupervised. ST4 you barely have to essentially achieve anything. ST5 is indirect. ST6 is ST5 is direct, ST6 is indirect, and ST7 is unsupervised. So in ST4, you really are a junior registrar. You're not really expected to do anything without any supervision at all. What else does the training include? Well, it includes placement in an ambulatory care unit. So essentially, this should be about half a day a week. You should also be, so new to the curriculum now is that we're going to have to learn ultrasound as a procedural skill. So when I started training, that wasn't something that you necessarily have to have. Now you're going to have that, and you should be allocated 1 day a week to be able to obtain that skill. And that is alongside a specialist skill as well. So as already stated in their kind of acute medicine clinical capabilities that you're expected to have a specialist skill. And that can be anything, and I'll go into that on another slide coming up, but essentially at the beginning you focus on your ultrasound. After you've got ultrasound completed, that usually should be over the course of a year or year and a half, you can then start focusing on your specialist skill, which again should be allocated about a day a week. So as part of acute medicine, you have to do your acute medicine training, but you also have to rotate amongst a number of other specialties as well. So for example, the ones that are listed and that you have to complete are cardiology, respiratory, geriatrics, ITU, and the acute medical unit. But you can do anything. In the UK, I did a year of gastroenterology. It really depends on where you are placed. But these are the ones that you have to do and have to get signed off because they're part of that acute medicine and clinical capabilities. As I've said, you're allocated some time to perform that specialist skill, even within those specialties. And you also have on-call commitments, which are the same as any other medical registrar. So that's a big talking point. I think a lot of people don't want to go into acute medicine, especially in the UK, because they're worried that they may have to do more on-calls than other specialties, but actually you don't do any more than any other specialty. You're doing exactly the same. Unlike other specialties, well, that's not necessarily true, but unlike most specialties, you can also dual train with ITU in the UK, but that does extend your training. It extends it by probably about 4.5 years. So it's a big commitment if you decide to dual train with ITU. So in terms of specialist skill in the UK, you can do anything. So procedural skills can involve ultrasound, bronchoscopy, gastroscopy. I wonder how, I mean, prior to kind of this new ultrasound skill being introduced into the actual curriculum in general, I imagine that now ultrasound will probably have to be more of a BSc accredited ultrasound rather than just doing a POCUS course. You can also perform an additional qualification such as medical education or leadership, or you can have a specialist interest in something other than the main specialty. So some people choose stroke medicine, some people choose palliative care, some people choose tropical medicine, and there's a long list of specialist skills that you can develop. Essentially, you can pick anything as long as you can prove that you're showing a commitment to it. So we've kind of already touched on this through the other talks, but essentially to be an acute medicine registrar, or to what is an acute medicine registrar, essentially in the UK, it means that you're working with a number of different people, a number of different patients. It's quite fast paced. You often come up against a wide variety of kind of medical challenges, and you're managing the sickest patients a lot of the time, which is why we do incorporate ICM into the training, because you need to be able to manage sick patients, and actually part of the new procedures that you have to learn as part of the kind of the new curriculum will be arterial lines and setting up CPAP machines, because often the acute medical unit can be seen as like a level 1 care, but the idea will be potentially in the future to kind of expand that into kind of HDU type settings, especially in wake of COVID, where we realise we just don't have enough of these beds on medical wards. You learn a wide variety of procedural skills, as I've already gone through. And especially in the UK, and I imagine in Bangladesh or across the world, because it's a new specialty, you have the ability to develop the specialty, and the specialty is always changing. Therefore, you can really develop these leadership roles, and really we can make acute medicine how we want it to, how we feel it should run, and how we want it to be. And we have a really prime opportunity to do that with it being such a new specialty. So just briefly, we've already seen what the day in the life of a consultant has been in the acute medical unit. It's very similar, obviously, for a registrar. In the morning, you'll meet the post-take consultant. This is on the AMU unit. You would meet the night team, see who's coming in the post-take, perform your AMU ward round, ideally complete that by 11, have some coffee, allocate jobs. Between kind of 11 and 1, you really want your juniors to be prioritising the discharges, getting the patients out, making the referrals, and also making sure your scans are done early on in the day rather than later. As a registrar in the acute medicine unit, you're probably always going to be around helping your juniors, especially because you do work with a lot of F1s and F2s who might need that extra support. Lunch obviously is between 1 and 1:30. Doesn't always happen at that specific time, but you, like Dr. Saman was saying, you should always aim for lunch. In the afternoon, it's usually a bit more chilled out. You have time to maybe make phone calls. Back in the day of meeting people face to face, obviously you'd be having family meetings, but now a lot of it's done via telecommunications. Depending on what you have based on in your week, you might have time to do your ambulatory care clinic, you might be doing your specialist skill that afternoon, you might be off doing procedures, you might be reviewing new patients or sick patients on the ward. So it just depends how you've planned your week. You often meet with the nurses again prior to kind of going home, and then ideally at 5, you would want to hand over to your long day SPR. I think acute medicine, saying that it starts at kind of 9, it's probably less likely in the UK. We usually have like an 8 till 5 day, depending on where you work, I guess. But obviously you kind of want to be starting when the post-take ward round occurs. So just a bit about Take Aim. We have this specialist kind of organisation which is funded essentially by Health Education in England in the UK, which is promoting acute medicine across the UK as a specialty. It usually recruits about 4 to 6 trainees. You do get a bit of a grant to kind of use towards your education and training during that period of time. And the idea is that we as trainees would hold regional sessions and where we're based, promoting acute medicine, and also a conference once a year, and a number of other activities. For example, we did an interview workshop this year as well, and we often kind of meet with medical schools and other kind of junior doctors to kind of promote the specialty. Obviously, due to COVID, things have become more webinar based, but we're hoping to get things started again when COVID restrictions settle down. You can find us on takeaim.org. You can also follow us on Instagram and on Twitter. We often do kind of showcases of current consultants working in acute medicine, talking about their specialist skills, and also how to get into acute medicine as well. So just in case you are thinking about your CV or how to get involved in acute medicine in the UK, so obviously you can join a Society for Acute Medicine. They have a conference coming up very shortly in May, which has a number of really, really good lectures. Obviously things are always better face to face, but we kind of moved forward with the COVID restrictions, so everything will be virtual this year, but it should still be great. Obviously, you can try and do some audits and quips, and try and publish as I made it seem quite easy there. I know it's difficult, but obviously a simple case report can, you know, if you submit it, potentially can get published. The RSM prize website is, I can't shout this out enough, it always has prizes on there which people can get into and just submit anything. And even if you kind of get a poster at one of the RSM regional days, it's really good for your CV. You can obviously get involved in courses. Having the basic ultrasound course will really do you well in acute medicine if you're thinking about applying or setting it up there. And then finally, obviously, leadership and teaching are really important to acute medicine, so it's always important to get involved in that wherever you are. So I will end there. I'm sorry if I spoke really fast. I will leave questions to the end, and obviously this is just the Take Aim website. Oh, and this is just the training pathway for acute medicine ICM, but I'm sure it will obviously be different for where you guys are.
Thanks, Jake. That was quick, but a lovely presentation, and I think you covered what we wanted to know regarding the role of a registrar and how acute medicine you can pursue a career. So that was quite useful. So thank you for that. We're here now where we've heard 4 very lovely talks on different components of related to acute medicine. So that's been enormously useful and quite educational as well. And we've had good humor as well, especially the lunch part was really good, Dr. Zaman. I wonder whether you always treat your juniors with those lovely Turkish lunches. So
as frequently as I can.
So we would want to work with you, I think, more frequently then. So I think now we are at the stage where, you know, the whole idea of this webinar was to see how we could translate what happens in UK in acute medicine, with UK being one of the 4 leaders in developing acute medicine as a specialty in as a specialty, and how much we could translate that and how feasibly we could translate that to Bangladesh. So we've got 4 distinguished experts in the field of medicine from Bangladesh, and we're lucky to have them today here in this webinar. So I think over the next hour or so, what we will be discussing is how much is this feasible and whether it's feasible to kind of develop acute medicine as a specialty in Bangladesh. So just from my experience in working in Bangladesh, I can say that in Bangladesh, there is the Department of General Medicine is quite developed. So what they do is the Department of General Medicine is called, or internal medicine takes a lot of direct admissions. So in that way, works similar to what acute medicine does in a hospital, but obviously there are direct admission under specialties as well. So it's a bit of a mixture between medicine directed admissions and specialty directed admissions. So anyways, what I'll do now over the next 1 hour or so is like to hear more from the 4 distinguished experts we've got from Bangladesh. So we will start with Professor Dr. Titu Miah sir, who's the head of school of the largest academic hospital in Bangladesh, as in the Dhaka Medical College Hospital. Dr. Titu Miah sir, if you're here with us, we would like to hear from you, your opinion, and if you have any questions to the four experts from UK, feel free to ask them any question.
Thank you, Ryan, for your nice moderation, and I'd like to thank all the speakers, brilliant speakers, for their presentation, which was very much impressive and full of content. And especially, I have learned a lot of informations and a lot of things regarding the acute medicine. We know this is very much happening in UK and in probably some parts of the Australia also. They have started the acute medicine, and Nicholas has very nicely mentioned it is also going to be started, or they have already started in Singapore and New Zealand. And what I want to mean, these sorts of services is very much essential in all over the world. And we have come to learn from the speaker's talk that it saves the life. The mortality rate definitely reduced, and also save the time to staying of the hospital. And as a result, also the saving of the money from the government part, also from the individual patients. And besides, in acute medicine, the services to the patients can give some satisfaction, definitely more than what is happening in our country right now, because the consultants are always there in the acute medicine area, where people can easily encounter the consultant who is rendering the opinion, giving the services, and immediately. And what is happening in our country? Uh, Actually, there is no such facilities, or very few, not in the form of typical, acute medicine unit. What is going on in England, in UK, and other advanced part of the world? Definitely, people like a country like Bangladesh, where we are very much densely populated and we are overburdened with the patients. And Ryan definitely knows, and all other my colleagues of Bangladesh will be agreed. We are overburdened in our government hospitals and other hospitals with the patients. And the patients are directly transferred from the emergency department to the general wards, especially in the internal medicine. And as a result, there are some catastrophe, is happening while the patients is transferred without appropriate care from the emergency department. And it is impossible for them to diagnose immediately, to render the immediate services, immediate interventions, or some other emergency services, which is essential within a few minutes or within hours. But in the general wards, we are also overburdened. The doctors is very much overburdened with these patients. So the patient's care is very much neglected due to in our happening. So if there is acute medicine, at least we can render good services, and also the time of the patients, the staying in the hospitals will be reduced tremendously. And in our country, in our postgraduate colleges, the Bangladesh College of Physicians Surgeons is trying to developing the acute medicine subspecialty. We are in the very much initial stage. We are going for some curriculum development, and we will be benefited from this today's last lectures, which is about some extent about the curriculum. And we are also trying in the government level how can implement such an unit. So we can definitely take some help from our speakers and from the the team which are working for the acute medicine department, acute medicine in England. And I'm sure in the near future, the exchange of views and regional collaborations will definitely help us in our country to build up these sorts of acute medicine unit and acute medicine subspecialty in Bangladesh. And we are trying to letting the government, we are trying to understand the government, and it is a very much essential part, and the people of Bangladesh will be benefited. And definitely we need to build up our subspecialty regarding the acute medicine, and sure, certainly those who have got the knowledge on, or they have got the specialty on the internal medicine. I like to thanks again the organizer and especially the Ryan for connecting me and allow me. And I have enjoyed a lot about listening the speeches from the speakers, and I'm waiting to listen from my colleagues of Bangladesh. Thank you very much.
Thank you, sir, for your valuable opinion. So one of the interesting things which happens in Bangladesh is there is a significant difference in how the government hospitals render care to their patients and the private hospitals render care to their patients. So and when I say talk about the difference, it's not only the difference in the quality of care, but also the difference in the system of like care. So the healthcare system varies quite a lot depending on whether it's a private hospital or a government hospital, which would be different to that in UK, because in UK, the private hospitals do not usually render emergency care. So I think that's something quite interesting. So having said that, I have got Dr. Raihan Rabbani sir, who's one of the leading experts in critical care in Bangladesh. And he's also a consultant in acute medicine in one of the largest private hospitals as well. So I'd like to hand over the floor to Dr. Raihan sir, but my one specific question from my side would be that having talked about the difference between the government and the private hospitals, how do we think the private hospitals in Bangladesh, who do render quite a lot of emergency services to the population, how can they play a part in developing acute medicine as a specialty if in the days ahead? And Dr. Raihan Rabbani sir, if you have any questions for our experts from UK, please feel free to do so.
Thank you, Raihan. Thanks to the renowned speakers from UK for their enlightening sessions today. So I properly concur with Titu Miah sir that in Bangladesh we are lagging behind. So in Bangladesh and UK, the main difference is the systems are different. That's the one thing. In Bangladesh, we have a mixed system of admitting patients, treating the emergency patients, and most of the patients comes to the emergency room, then goes directly to the general ward, and the acute part of the management is mostly missing. And we have a very scarce acute facilities. The ICU and high dependency units, they're very scarce in the government hospitals. And even those hospitals who have ICUs, the service is not that prompt, and the emergency doctors and general doctors are not well trained in ICU manners, not well trained in BLS, SALS, intubation, and all those things. So the bridge is absent in Bangladesh. On the other hand, in private hospitals, the emergency rooms are a little more equipped compared to the government hospitals. But even in the private hospitals, the most of the acute care part is done as an inpatient. So if we look at North America, so what they do most of the acute care part in the emergency room. So they have another specialty they call the emergency doctors. So they train people in the emergency specialty, they stabilize the patient, they diagnose the patient, then usually they decide whether the patient needs to go to the ICU or the intermediate care or in the general floor. So from the emergency room, those patients are getting stabilized, then going to the inpatient area. In UK, so they have established an intermediary. So that's the acute care. So in Bangladesh, we don't have that intermediary, and we don't have a strong emergency room in Bangladesh. So as a result, the patients are suffering. So depending on the planning of our policymakers, we can go either way. We can strengthen the emergency room, or we can make another department, like we can establish the acute care. So me, myself, I'm in favor of establishing the acute care medicine in Bangladesh. because if we go ahead and do that, it requires less resources, and we have many trained people in general or internal medicine, and they can contribute and they can learn quickly to be a acute care physician. So it's more feasible for Bangladesh, and I think the patient will be benefited. And as Professor Titu has said, that one of our leading postgraduate institute, they are trying to build up the acute care subject. I would also request Professor Titu and those are in academic environment in Bangladesh to maybe the university, medical universities can come forward and also try to establish the acute care. And the policy and the government should also concur that in which way we want to go, whether if we want to build up a better emergency room or if we want to fill up the breach, fill up the gap with the breach of acute care medicine. So I think that's all from my part now. Thank you, Ryan.
Thank you, Dr. Rabbani, sir. So one of my questions basically is that in Bangladesh, when we have a well-developed academic training system for developing general medicine's experts, can't general medicine experts then take up the role of acute medics? Because as we know that acute medicine is just general medics working in the front door. So do we actually need to form acute medicine as a department, or can general medics take the burden of that?
My opinion, like I am a general medic, so I was trained as a medicine specialist in Bangladesh, internal medicine. So I did the post-graduation here. Then I went to USA, got trained there in internal medicine, saw the emergency, got trained in emergency and ICU there also. So in my view, the general medics are not acute care physicians in Bangladesh right at this moment. So most of them will be doing the what they call it hospitalists in USA. And in Bangladesh, we can do the inpatient as a general medic. But the pace, the acuteness of the care, that's not built in our training, as we don't have that much care in the training facilities. So it would be the easiest thing to pick up the acute medicine for the general medics in Bangladesh, but they have to have some training. Either they have to get self-trained, or it would be better if we can provide them with some guideline or some courses to make them acute physician in Bangladesh.
Fair enough. Thank you, sir. So I would like then to hand over the floor to Dr. Ahmed Morsalanam. He's one of the associate consultants in critical care medicine, and also one of the associate consultants of the COVID unit of Square Hospitals Limited, which again, like I said, is one of the largest private hospitals in Bangladesh. So Dr. Anam, I'd like to hear your valuable opinion on this. You're somebody who also was a fellow of the Royal College of Physicians of Edinburgh. You trained in acute medicine for a year here. So it might be, you might be in a good position to kind of share your opinion of how much we can translate, and if we can actually translate some of the acute medicine things in Bangladesh.
Thank you, Raihan. Yes, I have been trained as a fellow of acute medicine in Edinburgh, both in Western General and the Royal Infirmary. Even 3 years back, before I went to Edinburgh, I did not know what acute medicine is or was at that time. So when I worked there, I found that it has very crucial role in management of the patients. And I found that it's really what's needed in Bangladesh. Professor Titu and Dr. Raihan Rabbani has already given quite a clear picture of how patients are managed in Bangladesh in both government and private hospitals. When I returned home and joined again as the lead of high dependency unit of Square Hospital at this moment, I found myself in a perfect position to render the acute care for patients in my hospital. It's not the complete critical care or not even the general medicine, but it's a position of both going both way, the bridge way, as Dr. Raihan Rabbani mentioned. Definitely, Bangladesh does have the scope for acute medicine. And from my point of view, I feel it's not the scope we should look for. It's the necessity for Bangladeshi patients, and we should look forward in every way to establish the department. And I would like to help in every way I can from the whatever knowledge I acquired in Edinburgh in United Kingdom, and whatever I'm trying to deliver to my juniors here in the high dependency unit of Square, what I have learned from United Kingdom. And I believe I can help in development of acute medicine in Bangladesh, and that will help the patients of Bangladesh, the population of Bangladesh a lot. That's, I think, what I mean, that's until now my point of view. I would like to hear from my seniors again. Thank you, and thanks all the speakers for the very informative presentations, and I have learned again a lot from all of you. Thank you very much.
Thank you, Dr. Anam. So we also have, as one of our distinguished experts from Bangladesh, is Dr. Shihan Haq. He is also one of the associate consultants of the critical care department, and is also an associate consultant of the COVID unit in Square Hospitals Limited. So Dr. Haq, I would like to hear your opinion as well. And one of the things I would also like to hear from you is the interaction between the medicine department and the emergency department and the critical care department in Bangladesh, and whether that has got any scope for any changes, and whether any changes are necessary in that regard as well.
Thank you, Dr. Raihan. First of all, I'd like to thank all the distinguished speakers for their excellent speech. Actually, I learned a lot from them regarding the organization of the acute medicine and how it works as a department. Because we already know that we don't have this specialty in our country at this moment. But I think acute medicine as a specialty is very much needed in our country. Because, where I work in a private sector in a tertiary hospital, here we have seen that sometimes the patients from emergency department who need further evaluation, but probably maybe for respiratory system or any other support. And these patients are shifted to ICU. But probably these patients were not the actual candidate for ICU. They can be managed in an acute care setting. So in that case, we are wasting the resources of ICU, but we cannot put this patient in general ward because these patients need monitoring. So in intermediate care, like acute medicine is a very much needed area, I think. And another thing that Dr. Raihan asked about the interaction between medicine. Yes, also in general ward, we have seen that sometimes if any, maybe at the middle of night or any time when the consultant is not present, sometimes if patient develops any acute situations, the doctors, usually the junior doctors in the ward, may not manage it or may not diagnose it properly. So sometimes they send the patients immediately to ICU for further evaluation. I think in this scenario that when we work in ICU, we found that these patients may not need ICU care, but it can be managed in a different way, like in acute medicine setting. So I think if we can develop this specialty, I think it could be a bridge that already told by Dr. Rabbani sir and Professor Titu sir about it. And regarding the, I also would like to take opinion from the distinguished speaker regarding if we want to train the junior doctors in general medicine ward regarding the, acute care diagnosis and how they can manage in the area when the consultant is not present. So could it be a good idea that the general medicine doctors can have some rotation in ICU or HDU setting like that, because we don't have any acute care, acute medicine department?
Dr. Cooper, would you like to share your opinion about this question? Like, is there a role for the critical care team to kind of train the doctors in general medicine, or because the system tends to work a bit differently in Bangladesh?
That's what I did when I was a junior doctor, and I did it because at the end of my medicine rotation, there was a situation where I was dealing with a sick patient to the best of my ability. And then the next morning I handed over to an anaesthetist who was doing medicine for 6 months. And just a very brief conversation with him, I realized there was so much I didn't know. And I was quite annoyed about that, because I thought to myself, why have I not learned this? It's really important for my job. So I decided that I was not going to be a medical registrar until I'd done intensive care. So I worked in an intensive care unit for a year and spent the whole year being shocked at the training I'd had previously, because sick patients are everywhere. Then sick patients don't find themselves in intensive care. They're literally everywhere. And so I think that's really important. I've been so fascinated by everything that people have said, because I mean, I'm quite old now, but it really was like a bit like Bangladesh when I was doing my house jobs in the UK. So overcrowded emergency departments, patients being admitted, not necessarily being stabilized or diagnosed or treated properly, going to every ward all around the hospital. I was on call, I had a list, I had to walk miles. People weren't observed properly. There was no national early warning score. People would have a blood pressure of 70 for 2 days until they arrested, and then you would realize they were sick, because the nurses wouldn't recognize the sick patient because they were talking. I mean, in the last 20 years, not only has the National Health Service embedded a lot of systems and processes to make things safer, but we have reorganized. I mean, acute medicine, by the way, started with 3 men, 3 people. They went about 20 years ago. They went to a meeting at the Royal College of Physicians, and they were quite disappointed by the response. And so, like we do in England, they went to the pub to discuss the matter. And that is how the Society for Acute Medicine was born. 3 very passionate people who saw the need for a reconfiguration of services and reconfiguration of training. And look what that passion from a small amount of people can do in just 10 years. So I really think that the UK was where some parts of, Bangladesh may be now. And that's good, because it means you can definitely do whatever you feel you need to do. It's important to tailor to local needs, and obviously to start where you are. But I can really see from what you've said, incredible advantages for patient safety, for efficiency of how physicians work, and reducing length of stay, which reduces overcrowding, all those kind of things.
Yeah. So Dr. Zaman, you're one of the dual consultants in acute medicine and critical care medicine. So do you think in countries where acute medicine does not exist as a specialty, in order to train people in general medicine better, can there be a partnership between the general medicine department and the critical care team? Do you think that's, what's your opinion about that?
Well, to be fair, it depends entirely on the structures in the critical care department. What you need to keep in mind is, in a lot of these places, critical care is run by the anaesthetist. A lot of the places have open units rather than what's true to the UK, where you've got closed units. That means that the admitting consultant remains responsible for the patient throughout their patient journey in an open unit. Whereas in a closed unit, the intensivist takes over care and then relinquishes that care back to the specialty once the patient is out of critical care. And those things have direct implications for any kind of communication or training, as I expect what you're asking, really. Because even things as simple as a ventilatory approach or approach to how to give vasopressors differs quite significantly depending on how you were trained and how you think. Okay. So those factors need to be very much kept in mind whenever somebody is planning anything about what to do next. Because you might want to say that we can transfer skills, but it's not just skills you're transferring thinking mindsets. And that mindset requires very much an understanding of the system. That's how I ended up doing everything I do, that I'm working in ED, I work in acute medicine, I work in critical care. What you realized was that unless you understood the mindset of the person you were going to talk to next, you couldn't really communicate your needs and the needs of your patient as well as you could otherwise, at least not when I was training. But as I got through my training, I realized that, okay, fine, there are salient features to how different people or different specialties approach the same problem, which separates them or puts them apart. And an acute medic's job is to figure out what the other guy would want and then kind of deliver it in an efficient way. Yeah. So a simple answer to your question really is, it depends, rather than a simple yes or a no, on what constitutes the critical care unit that you're hoping people can go to and see things being done.
Fair enough. Yeah, makes sense. So Dr. Rabbani sir, Dr. Raihan Rabbani sir, I've got a question for you as well. So you being one of the dual consultants in acute medicine, in internal medicine and general medicine at Square Hospitals Limited, do you think that without acute medicine existing as a department, if somebody under the Department of Medicine becomes really unwell, but does not necessarily need an HDU or ITU transfer, can the Department of Critical Care Medicine provide outreach service in order to provide acute care for patients in the ward, and so to help their general medicine colleagues, so to ensure a better patient safety in that regard?
That's the idea that exists in North America. So they form up a rapid response team. So they just get called like a code blue team or something like that. So when a patient is crashing in the floor, general floor, either the nurse or the house officer, they initiate the call. The rapid response team rushes down there, try to stabilize the patient, and if the patient gets stabilized, the patient stays on the floor, and if not, they decide whether the patient goes to a critical care area or not. So that's one concept that is still functioning in the North America. So that can be done, but looking at the culture and everything, and you are still relying on the general floor staff for the call to initiate to figure out whether the patient is sick or not. So if the general floor staff misses that, the patient will be in jeopardy. So it will have some flaws. So it would be better to get an acute care medicine team rather than make a rapid response team or something like that.
No, fair enough. So in the hospital that I work, we also have got a similar team like that. So what it consists of is a medical team consisting of a registrar and two or three junior doctors. But there's also a group of specialized nurses called the deteriorating adult response team nurses, so DART nurses. So what they do is they sit together twice or thrice daily and discuss all the patients in the hospital, admitted in the hospital, who are potentially unwell and who would need a review by that team. So they then have a list on from the electronic records. They get the list of such patients and go around to see them. So I think this also highlights the importance of optimum record keeping within a hospital. So if you've got in a hospital an optimum record keeping where every single doctor has access to all those patients, where they are, how they are, what are their vitals, what are their observations, this is something which can be a good idea. So Salam, if you're still here with us, can I ask you, there is we in the UK hospital, we maintain a chart called the observation charts where every single patient's we can see what their observations are, where they are, and what support they would need. So would you like to enlighten us a bit about that?
Yeah, so I think many trusts, in fact, in the UK have switched over to using an online website called Nerve Center, where we keep the patient details, but also can record the patient observations. So it makes it very easy for things to be automatically flagged up to certain people. For example, if I'm on call for the medical wards, I can tick a box on my phone, which is logged into the system, saying that I am on call for the wards. And then whenever a patient is scoring more than 5 or 7 and I need to be made aware, then it automatically sends me a message. I think so far from what I've seen, because I have seen it when we used to use the paper charts, and I've seen it when we're using now with the online systems, it makes things a lot easier to use such a system. But even with the paper charts, having something like an early warning score, so that the nurses know when to flag up things to someone more senior, it did help a lot. Sometimes the nurses don't necessarily have the clinical knowledge to know when a patient is going to crash or when they're going to deteriorate. So having something simpler for them to follow, I think did make a difference nationally here in the UK.
Yes, I think that's quite useful, because when you have a list of all those patients who are potentially unwell because either they're hypotensive or needing oxygen or having a high respiratory rate, or spiking a temperature, this can easily, you can score on that chart, and people scoring high easily gets flagged up. So not only do the nurses know that they need to get a doctor involved quicker, but also we were talking about that critical care team, outreach team, who's got specialized nurses. They also get alerted and they get to see those patients, and then they can take a quicker decision on whether this patient is safe on the ward, whether this patient would need escalation to a level 2 or level 3 care, whether this patient is appropriate for a level 2 or level 3 care. So I think that's quite useful. This is something which we can potentially follow in Bangladesh. And one of the other things we do there is also in UK is, they realize that there is a need to train the junior doctors better in how to deal acutely unwell patients. So we have got the impact course and the ALS course and some of these courses. So if you're still here, Tig, would you like to enlighten us a bit more about those courses that we have in the UK? You're muted, Tig.
Yeah, I've unmuted myself this time. Obviously, ALS is a requirement for every registrar to have, and you need to have that competency every 4 years. So that needs to be validated. And I don't know if the similar courses are run in Bangladesh, or if ALS is done in Bangladesh, Latif, I don't know.
We have the ACLS, which is an American-run course, which again, it's not compulsory, but it's run as an option for interested doctors.
Okay, fine. I mean, I'm sure it's very similar, but obviously it teaches you about acute resuscitation. And obviously as a medical registrar, you're often the one leading the arrest situation. So it teaches you that, but it also teaches you about other stuff like human factors, which we're really big on in the UK, which I don't know if it's caught on everywhere else, I'm sure it has, but we look at a lot of courses and simulation based around human factors and what can go wrong, not just from a clinical perspective, but also from a perspective of people being able to work together as a team. As you said, we also have ATLS, which is a trauma-based one, which you don't necessarily have to do. Obviously, as medics, you don't often go to trauma, but it can be quite useful if you're thinking about the intensive care setting and knowing how to manage those patients. And then we have other courses, as you've mentioned, Impact, which again isn't a course that you necessarily have to do, but it teaches you about managing acute medical kind of emergencies, and also the alert course, which I think F1s and F2s do as well. And there is a specific ICM one, which I need to have a look at. I can't remember the name of it, but it's one that teaches you kind of the basic skills about working in an intensive care setting as well. So we have a number of courses that are run across the UK to kind of improve your skills, only of which I believe ALS for acute medicine is actually required.
So what we've been trying to do with that regards is basically the whole idea of having an organization called the Academic Forum for Acute Care Physicians is to kind of form an academic forum and try to organize courses and workshops to train the junior doctors better in acute medicine. So Dr. Anam, if you're still here with us, would you like to give us some more insight into what Academic Forum for Acute Care Physicians has been doing as an organization and, you know, trying to educate the junior doctors better in acute medicine?
Yes, thank you. Well, it's really a very young organization. We just started our journey from January 2020. We have tried to organize some courses, but the COVID disrupted everything. But even though we did some ABG courses, very basic for the junior doctors, we did some ECG courses for the junior doctors and intern students just graduated doing their FY periods in Bangladesh, and some online-based classes, especially with the School of Acute Medicine that with your help also, we gave some basic lectures, things on basic medical emergency management things. So we are trying to do our best in this COVID situation, and hopefully we will go a long way with all your help.
Yeah, that's fantastic. So one of the other things I've realized and especially for the junior doctors to improve their knowledge on acute medicine is read quite a lot on how to manage acute conditions from textbooks and from journals and from websites like UpToDate, which are quite useful. So in terms of books, I myself have read the book Oxford Handbook of Acute Medicine, which I found quite useful and quite informative. And then obviously there are other books as well. For example, I'd like to share a particular book here, which has been written by our like Dr. Cooper. As I said, she's an author of multiple books, and one of the books she has written is Essential Guide to Acute Care. So Dr. Cooper, would you like to take us through that book that you've written?
So remember the story of when I was so annoyed with my training that I went to do intensive care for a year. And at the end of that, I said to my boss, Paul Cramp, who's an intensive care consultant who's just retired, I said to him, I really want to write a book about everything you really need to know, but no one told you. And please, will you help me? And the first edition came out. Please don't buy the first edition because it's not very good. But it came out over 15 years ago. And the third edition has just come out. It's been extensively updated. And it's the first chapter is very relevant to our discussion because it's the story of patients at risk. So it's the story of how we developed early warning scores in the UK, the evidence base behind them, how ordinary general wards how you can put in systems that prevent deterioration and oblige inexperienced staff to call for the right help. And I remember before early warning scores were a thing nationally, I introduced a paper-based observation chart with early warning scores for a local hospital I worked at as a registrar, which made a big difference, and we trained people on how to use them. So it can be very, very simple. But yeah, the rest of the chapters are about the principles of looking after sick patients and helping you understand why we do the things that we do. Yeah.
So I think over the last 2.5 hours, we've had a really wonderful discussion over like the scope of acute medicine in Bangladesh and how we can learn from a place like UK, which were the leaders in kind of developing acute medicine as a specialty like as a specialty in a hospital. So I think in my personal opinion is every country is different, every healthcare system is different. So everyone will have to figure out their own way to sort out how they want to render acute care to the patients. But at the end of the day, one thing is common between all the countries. We all want our patients to be safe, and we all want our patients who are acutely ill to be taken care of in a prompt and an appropriate manner. And at the same time, we all want all doctors handling patients to be really equipped with the knowledge and skills to deal with an acutely unwell patients. So I think while the systems are different, these goals are common. So I do think that there is a scope for a lot of partnership in that regard. So, and I think every doctor should from their side take steps to ensure that they are equipped with the knowledge and skills to deal with acutely unwell patients, but also teach their juniors as well. So which is why we have kind of started the School of Acute Medicine. The whole idea is to equip the junior doctors with more knowledge and skills to deal with acutely unwell patients. So this was the start of our journey. From here on, we're going to be regularly holding webinars, and we're going to be holding lectures from distinguished experts, and also sharing educational materials and resources on various aspects and topics related to acute medicine. So I personally have really enjoyed the last 2.5 hours, and I thought it was a really interactive discussion between doctors from very different healthcare systems, but it was with the same goal and aims. So I really enjoyed it. Thank you all for your presence. If there's anything else anyone would like to ask a question to, I'll probably give the floor to that person, but otherwise I'll probably bring the session to a halt now. Okay, so it seems that we have run out of questions now. So we will probably end the session now. But again, thank you so much for everybody for joining this session. And it was a recorded session, so anybody, if they want to see it later, this will still be available from our School of Acute Medicine, which is a page in Facebook. So we've initially started our journey in Facebook, and then we gradually aim to expand it and eventually start a website when we reach there. So thank you so much, everybody, for your wonderful talks and your wonderful presence. I really enjoyed it myself.
Thank you very much.
Thank you.
Thank you, Raihan. Thank you very much.
Thank you.
Thank you all.